Over the next hour, we will discuss civil society advocacy for UHC and its impact, the background of the Health for All Advocacy Toolkit, how it can be used, and the needs it addresses. We'll begin with some scene-setting opening remarks from Dr. Justin Koonin, co-chair of the UHC 2030 Steering Committee. Justin is also co-chair of the World Health Organization hosted Social Participation Technical Network, co-chair of the SDG 3 Global Action Plan Civil Society Advisory Group, and civil society representative to the Access to COVID Tools Accelerator and the Health Data Collaborative Stakeholder Representative Group. He is also president of ACON, Australia's largest civil society organization working on HIV prevention, care and support, and the health of people of diverse sexualities and genders. Next, Eliana Monteforte will provide an introduction to the toolkit. Eliana is the Director of Special Projects at Global Health Council and a CSEM advisory group member. In this role, she leads projects and partnerships to ensure minority voices are systematically heard and included in US global health policy. Prior to joining the Global Health Council, Eliana worked at Management Sciences for Health for over a decade and was the coordinator of the CSEM Secretariat. We will then move into a panel discussion moderated by Dr. Justin Koonin, and we will then have time for a moderated Q&A session. So without further ado, I will pass the mic over to Dr. Koonin. Justin, welcome and thank you.
Thanks very much, Aisling. Can you all hear me clearly?
Yes, we can.
Good, good. So at the outset, let me say what a joy it is to be at this launch, the creation of a toolkit which will give civil society and other advocates the information and the resources they need to drive actionable change on UHC at the country level has been a long held goal. And here we are.
Sorry, so, can we slow down? Sorry,
yeah,
it's
sure,
the I'm just going too fast. Thank you.
No problem. We'll go slower. It's terrific that we have signed interpretation. So congratulations to CSEM and to the many partners who've helped make this happen. Our strength as a movement lies in our ability to join forces, and that's on full display today. So well done. Let's start at the beginning. What is UHC? Universal health coverage is based on the human right to health. It's the aspiration that all people can obtain the health services they need of good quality without suffering financial hardship when paying for them. It includes the full range of essential health services, health promotion, prevention, treatment, rehabilitation, palliative care, and mental health services. It includes increasing access to quality health services, but it also links closely to broader efforts to make progress on social determinants of health, like water and sanitation, like education, migration policies, workplace safety, and many others. In the context of the world we find ourselves in today, there can be no true pandemic preparedness without UHC. Indeed, we should see pandemic preparedness as the step zero of UHC. And at the center of all of these efforts are people and their communities, because without them, our health systems lack the eyes, the ears, the hands, and the hearts they truly need to reach the most vulnerable. We've had bold commitments at a global level. In 2019, UN member states signed a political declaration on UHC at the UN high-level meeting, and governments recommitted to achieving UHC by 2030 and reaffirmed the right to health for all. But how do we get there? The key asks from the UHC movement are core requests for governments and political leaders to take action on UHC. They were developed in the lead up to the high level meeting by UHC 2030 with collaborative input from a range of health and other stakeholders. They included ensuring political leadership beyond health, pursuing equity, creating a strong regulatory and legal environment, building quality health systems, sustaining public financing, engaging the whole of society in partnerships for UHC, emphasizing gender equality, and promoting strong, resilient health systems for emergency preparedness. The challenge in all of these global processes is to make them relevant at the country level. And that's where civil society and this toolkit come to the fore. Civil society is a vital bridge between decision makers and the end users of a health system. We are often best placed to understand and amplify the needs of communities, especially those who are marginalized and often left out of decision-making fora. And this has proved critical in our experience of and responses to the COVID-19 pandemic. And so to the toolkit, the Health for Our All Advocacy Toolkit has been developed specifically to build capacity to do these things. It was created to unite advocates across sectors in this common agenda. We're going to need our collective voices raised very loudly to really reflect the realities of people and communities and to drive the change, which is our goal and our right. And so a very warm welcome under the UHC umbrella from all of us at UHC 2030. And with that, it's my great pleasure to hand over to Eliana Monteforte, Director of Special Projects at Global Health Council and CSEM Advisory Group member, to walk us through the toolkit. Thank you very much.
Thank you so much, Justin. I just want to make sure everyone can hear me and see my screen. Okay, great. So welcome everybody. I am so excited to be here to just give you a quick overview of our Health for All Advocacy Toolkit. By way of background, the idea for this advocacy toolkit came in the lead up to the high-level meeting on UHC in 2019. So in the lead up to that, we actually hosted various country advocacy meetings with civil society and sometimes with civil society and government together to really talk about what the UHC gaps are in the country so that governments could arrive at the high level meeting knowing what they needed to commit and advocate for. So in the lead up to the high level meeting and during those meetings, we found that civil society really lacked the knowledge of universal health coverage, an understanding of how we define it, the ecosystem around universal health coverage, what all of the stakeholders are advocating for, and why it's such an important note to sing in the global health advocacy space. So we decided, based on the questions that we received at the country level, to put together a toolkit that would be useful for civil society to understand universal health coverage. Now, this toolkit has 3 parts. You'll see it up here. Part 1 talks about what universal health coverage is, how it works, why do we need universal health coverage? It gives you a brief history of universal health coverage and the UHC landscape. Part 2 talks about why it's so important for civil society to be a part of this global health advocacy. We've seen with COVID-19 that civil society, with or without support from the government, has been able to respond to COVID-19. And it's incredibly important for them to continue to have a space. And then part 3 walks you through how can civil society organizations create an advocacy plan for their organizations or their communities for universal health coverage. This toolkit also has key resources such as a glossary of terms, and it also has lots of videos for you to watch. So with that, I will hand it back to Ashley, and apologies for my 2-year-old, to continue the session.
Thank you so much, Eliana. Passing it over to Dr. Koonin to lead our panel discussion. Thank you so much.
Thanks very much. So we're delighted to have 4 panelists representing different areas of the civil society space at local, national, and regional levels. So I'll introduce them as we go. Our first panelist is Samuel Matsikure. Samuel's a human rights activist from Zimbabwe, who currently serves as the program manager of GALZ, an association that protects, promotes, and represents the rights and freedoms of LGBTI people in Zimbabwe. And Samuel, the question I want to ask you is this: you have extensive experience working with communities on developing programs with a legal and medical framework. Why is it important for marginalized communities to engage with and influence the UHC agenda? And in your opinion, are these communities well equipped for advocacy and accountability around UHC? Samuel, over to you.
Well, universal health coverage is important, especially for marginalized communities. As in the history of global health efforts, it holds a promise of reframing the global health agenda as it encompasses the health for all and the principle for right to health, which is inculcated and enshrined within country constitutions globally. It also is bolstered by the Sustainable Development Goals, in which universal health coverage is located. It also gives governments and communities an opportunity to address inequalities, access to quality, available, and accessible services. It also will help to develop financial mechanisms that will protect communities from other health services. It is therefore important that we do not leave anyone behind in this initiative, as member states, governments, and communities have agreed to the commitment to leave no one behind. Easy to leave out criminalized, marginalized, and those suffering from human rights violations based on gender identity and sexual orientation. There are lessons we have learned from the HIV response in the past as we adopt UHC. When governments and decision makers meaningfully involve communities and place them at the center of HIV response and other epidemics, we get better health outcomes. This has been proven through evidence in HIV testing, support of those living with HIV. Universal health coverage, while it is a beautiful concept, however, we still have laws and policies that criminalize some populations. And how will these groups access services without stigma and discrimination and not suffer out-of-pocket payments or have tailor-made health services that are responsive to their needs? These populations I'm referring to are lesbians, gays, bisexuals, transgender persons, intersex persons, sex workers, men who have sex with men, people who inject and use drugs, people living with disability, and so forth, who have for many years been indicated that social determinants, if they are not put in a way that is supportive, they continue to impact on these communities. There have been demonstrations around the world that some groups are continuously being left behind in universal health coverage, especially when it comes to provision of social health insurance, access to essential health services, and reduced cost of care due to criminalization. It is therefore important that all governments, civil society, communities fulfill their commitment of leaving no one behind, especially when we are implementing sustainable development goal, universal health coverage processes that are practical in reforming and ending laws that criminalize these groups, as the current laws reinforce exclusionary practices and promote hate. It is also important to create good governing structures that promote meaningful participation for all citizens in the universal health coverage processes. It is also important that we create platforms that are inclusive for these groups. While these groups are making headway, especially in the implementation and access to HIV services, the majority are being left behind within universal health processes. And in many cases, they're actually left out in health insurances, especially people living with HIV, in health financing plans, and also in developing strategies that works for these communities. This toolkit will go a long way in covering this gap and help marginalized communities to empower themselves to participate and contribute. My last call is to ensure that this toolkit being launched today fulfills the intended impact. And I call upon partners to make sure they support community health monitoring activities and initiatives at community level. I thank you.
Thank you so much, Samuel, for highlighting in particular the equity dimension and the need to make sure that UHC is truly inclusive and does not leave marginalized populations behind, and also the regulatory and legal dimension, because of course criminalization is such a huge issue. And those, as you will have seen, were two of the key asks for the UHC movement. To those of you in the audience, hang on to your questions, because we'll be having a Q&A with Samuel and the other panelists immediately after this panel discussion. So please keep them right at the front of your mind. For now, let's go from Zimbabwe to Georgia and welcome Natia Loladze. Natia is the president of the Georgia Red Cross Society and a member of the governing board of the International Federation of the Red Cross and Red Crescent Societies. She's an economist and has been leading the National Society in Georgia for nearly a decade. Natia, IFRC is the world's largest humanitarian organization, and as president of a national society, you're on the forefront of humanitarian emergencies. Can you highlight the role of these national societies in addressing UHC, with a focus on how you work with public authorities and build a strong community presence? Natia, over to you.
Hello, and thank you for the question. Since its creation, the Red Cross, Red Crescent has been guided by a clear set of humanitarian principles and values that aims in one way or another to effectively contribute to building resilience. We strive to meet people's basic needs for health, shelter, education, food, water, and security. Make every effort to ensure that the social costs and benefits are fairly shared by all and inequities are eliminated, that human rights, human dignity, and local values are understood and respected, and to ensure that non-renewable resources, biodiversity, and the environment are managed responsibly. As you might know, IFRC response goes beyond the provision of immediate relief to assist those who have suffered the full impact of the disaster. We also support communities rebuild their homes, lives, and services, and to strengthen their capacity to cope with future challenges. And due to its auxiliary role to the public authorities and its presence in the communities, the Red Cross, Red Crescent is in a unique position to play an advocacy and advisory role on resilience and accessing health to all. The Red Cross, Red Crescent can transmit the needs and aspiration of the communities on policy, social protection systems, infrastructure, laws, and governance issues needed to create an adequate environment for resilience at national level. The Red Cross, Red Crescent is present in more than 192 countries with a huge community of health workers and volunteers. So when disasters occur or conflicts, Red Cross and Red Crescent volunteers are often able to operate in contexts where other sectors can have difficulties to access. They are well placed to support communities to meet the needs they face, so whatever those needs may be. In the past years, the IFRC has taken a prominent role in the process leading up to the UN General Assembly high-level meetings on universal health coverage and follow-up process. So there are several reasons. First of all, we see a real humanitarian need. Second, we strongly believe that our national societies, Red Cross and Red Crescent societies, and community health volunteers are an essential means of achieving universal health coverage. We believe that momentum towards universal health coverage provides an ideal platform for our national societies to engage with their health ministries and strengthen their health services. So the Health for All Advocacy Toolkit is going to provide Red Cross, Red Crescent National Society with an extremely useful tool for further achieve their commitments towards local communities and populations. Thank you.
Thank you so much, Natia. And not only is IFRC the world's largest humanitarian organization, but it's also been a terrific supporter of CSEM and of the civil society movement for UHC, including, as you said, in the lead up to the last high-level meeting. And we very much look forward to continuing that partnership. So thank you. Let's go from Georgia back to Africa, and actually to Kenya more precisely, and welcome Collins Masinde. Collins is a trained social worker and community advocate from Bungoma County in Kenya, where he leads the Youth for Sustainable Development chapter. He recently coordinated a UHC-driven community intervention supporting women and girls with disabilities to advocate for inclusive and equitable healthcare. And this intervention has been highlighted as an example of good practice in the Health for All Toolkit. So Collins, my question is this: based on your experience, and especially in this project in partnership with White Ribbon Alliance Kenya, how do you see communities and civil society champions playing a role in addressing the gaps in UHC implementation on the ground? Collins, the floor is yours.
Thank you very much for this kind of question. I want to begin by highlighting how we did this project in collaboration with White Ribbon Alliance Kenya. UHC, for me, a project in Bungoma County targets girls and women living with disabilities. And in Bungoma County, we try to advocate for improved service delivery in 2 health facilities. And our key objective was to have cleanliness and also have the inclusive facilities in terms of having good toilets for people living with disabilities, and also having sign interpreters, and also the facility to be very much inclusive. And who are the people that were involved in this kind of project? Is in our project, we have the community, and this community we are targeting the girls and women living with disabilities. And from the communities, we also had to recruit some disability champions. And we also had the Health Facility Management Committee, the County Management Committee, and YSD as the civil society championing for the health services of the people that live with disabilities. And how are we doing this? We were doing this through what we call community validation meetings, community hearing meetings, and also creating a roundtable meetings whereby the girls and women living with disabilities could sit with the people making decisions so that they can raise their issues. And for the communities who are the direct beneficiaries, the girls and women living with disabilities, we would say that the girls and women living with disabilities, are the direct beneficiaries. And so the girls and living with disabilities were people that who actively participated in raising their concerns, and also the people that sit on the table and discuss with the decision makers about what they need as the women and girls living with disabilities in Bungoma County. Through this kind of project, having implemented this in our grassroots organizations, there are some gaps that we have identified for us to achieve the UHC for Me project. One is there's poor healthy priority settings, because you find that in counties, they set priorities not basing on what the women want, but they set priorities basing on what they think is good for them. And also there is no, what we call this, there's no health accountability systems within the county government of Bungoma, because a lot of funds, yes, they say that the health system is being underfunded, but we are seeing a lot of funds being lost due to lack of the accountability systems in the matters health. And also making the decision making is centralized, so it takes long for making the decision to create action. So from this kind of a project, there's some lessons that I learned as a champion leading this kind of project and spearheading the UHC for Me project. One is there is what we call inclusivity and participation of all communities. To achieve UHC for Me, there must be inclusivity and participation of all community key stakeholders. That is the only way that we can have to achieve this. And also, in my recommendation, I would say that for us to achieve the UHC for Me targeting girls and women living with disabilities, there is need for the strengthening and empowerment of women and girls living with disabilities networks at the grassroots level to make sure that they are able to advocate for their own rights. And two, for us to achieve the UHC for Me vision, each county needs to set up a UHC alliance to help push for its agenda as a team, because for us to achieve this kind of journey, we must do it collectively. So to end my submission, I will request that grassroots empowerment for social change is key to achieve the UHC for Me objective. And at this end, I would like to thank White Ribbon Alliance Kenya for holding us hands from the grassroots to this level. Thank you very much.
Thank you very much, Collins. And I think what you've highlighted is critically important, that it's as important to highlight and to engage the grassroots as it is to engage the large international NGOs. And so we hope to do that in our work, and we hope to do that with this toolkit. So thank you very much for joining us. I'm sure there will be questions for you shortly. Now let's move to Asia. Welcome Adi Marte. Adi is the Executive Director of APCASO, a civil society network in the Asia Pacific region that serves as a platform for advocacy and community systems strengthening for health, social justice, and human rights for the most vulnerable and marginalized populations. Adi, you have extensive experience in mobilizing communities and civil society action for health, and very recently, APCASO led focus groups across Asia with CSEM, where civil society discussed the progress made towards UHC. Would you speak to some of the most successful movements you've seen and any characteristics you think are essential for a good advocacy campaign? And also, what were some of the challenges that civil society faces while influencing policy and protecting the right to health? Adi, the floor is yours.
Good morning, good afternoon, good evening, colleagues and friends. Hi, Justin, and thanks for the question. There are countless social justice movements, a number of them I'm part of personally or engaging with via APCASO. The HIV activist movement, the TB activist movement, the women's movement, sexual rights movement, lesbian, gay, bisexual, trans, intersex, and queer movements. I think one can describe movements in terms of maturity or reach and scale or longevity of existence, but it would not be really apt or fair to describe movements as successful or unsuccessful, because movements exist as acts of resistance against an unfair or an undesirable status quo, and they tend to remain as long as that status quo isn't yet changed. So what we will tend to have are movements that are still in struggle. This does not mean that the different movements have not been winning battles. They have just not won the whole game yet. However, if we talk of successful or unsuccessful advocacy campaigns, then yes, there are a lot of lessons we can take stock of. If I am to limit to three, For the benefit of time, my answer to the question, what makes advocacy campaigns successful or how does change happen? It will be this. One, change happens through change movers and ground shakers. These are individuals, organizations, or community groups that are brave enough, and let's admit it, crazy enough to fight the fight. Those that speak up and say, enough, there is something very wrong and we need to make it right. These individuals and groups often spring up organically, but sometimes their movement needs to be facilitated or fostered. Sometimes they also need to be funded. Resources and tools such as the CSEM UHC Advocacy Toolkit are important, but the most important thing is for those most affected by the problems to be at the front and center of the campaigns. At the end of the day, they need to be the ones setting the change agenda and devising and implementing the strategies to achieve the changes. Everyone else are facilitators and supporters. Second, change often happens slowly and in a non-straightforward manner. There is always the need for nimbleness, creativity and adaptability in strategies. How we get there needs to be suited to what will work. And what works often changes from context to context and over time. The important thing, though, is while we are flexible with the strategies, we are always crystal clear of our objectives as well as non-compromising of our principles. Because how we go about advocating for change is as important as what we are advocating for. Third, but not the least, we need to remember that not all change always happens for the better. There will be moments in an advocacy that we would get backlash for our success, that we need to take 2 or 3 or more steps back for every step forward. We have to know that such is the life of advocates and advocacy, and advocates need to commit for the long run. In any case, fundamental ethical principles need to be upheld. One is that of benevolence, meaning that we should always do whatever is for the good. The other is non-maleficence, meaning in whatever we do, we should never do or cause harm to the communities that we intend to serve. So just for the benefit of time, for me, these 3, though they are not the exact recipes, they are essential ingredients in advocacy campaigning and movement building.
Thanks so much, RD. And I think it's fair to say that APCASO has been at the forefront of leading the civil society charge for UHC, including with your paper, the UHC that we want, which was really one of the first to discuss these issues, both at a regional level and globally. So congratulations, thank you. And we need your experience, and it's terrific to have you here. And thank you to all of the panel for those really well-considered remarks. We're now going to move into a Q&A session, and I have the pleasure of handing over because this session will be moderated by Cedric Ninina-Hazwe, who is the Global Advocacy Manager at GNP+, the global network of people living with HIV. So Cedric, over to you.
Apologies. I think Cedric had an issue, so I will take over. My name is Karti Manikarot, and I am the Communications Officer for CSEM. The first question we have is for Ms. Natia and Loladze. In your remarks, you talked about certain community groups that often lack adequate access to healthcare coverage. What lessons were learned during this COVID-19 pandemic on equity, and how can unmet needs be addressed to create inclusive, equitable societies that leave no one behind?
Thank you. Our vision is to enable healthy and safe living for all. We seek in particular to reach the last mile to provide health and care to those who are outside or at the margin of the formal health sector. We put the people that we serve and support at the center of all our actions. They are the experts in their own context, and they must remain as the key architects and agents of change in any efforts to meet their needs and improve their health status. So communities differ within and among countries, but frequently include aging populations, people affected by disasters and crises, the poor people who are, and people who are discriminated, migrants, people living in remote settings, and people with disabilities. Likewise, barriers to access for these populations, whether legal, economic, geographic, human resource related, or social, will vary from context to context. So, and another thing is that the challenges facing the global health community are centered on gender dimensions. Since more than 70% of the health and social care workforce globally are women, and unpaid care represents half of women's contribution to global wealth. Resilient health systems and universal health coverage cannot be achieved without consideration of gender equality in empowering women and girls around the world. The COVID pandemic clearly demonstrated the need to act locally, close to the populations. Well-designed community-based health programs are the most promising and flexible ways to ensure a basic level of access to health services for communities, especially those living in already fragile settings or at risk to be left behind. So as it is with our experience and country consultation have told us that health is ultimately a community matter. Sickness, disease, and even pandemics start in communities and will end in communities. We strongly believe in ensuring the engagement of communities and CSOs in decision about their future and participating in the fulfillment of the universal health coverage agenda. We hope for greater investment in human resources for health in terms of quality, quantity, primarily on community health workers and community volunteers, CSO, community advocates, and other implementers who play an important role in the community health. We need to prioritize health needs of vulnerable and marginalized communities, not served by formal health systems, and as well support the capacity of CSO and communities of countries in disease outbreak preparedness, detection, and response. We must ensure financial protection for individuals and families exposed to catastrophic health expenditure. So during the country consultation meetings, actually guided by the Georgia Red Cross Society, participants in one voice highlighted the importance of universal health coverage with the following statement. It is the time to review the national healthcare system based on public interest and find the pathways to achieve universal health coverage, leaving no one, especially people under vulnerability, behind. So the IFRC and its member Red Cross and Red Crescent national societies, including Red Cross, remain committed to continuing to work towards achieving sustainable development goals, including universal health coverage, and ready to contribute based on the principles of public health development and rights. Thank you.
Thank you so much. We're really grateful for this partnership with IFRC and the Red Cross Societies, and really appreciated partnering with you on the country consultations. The next question is open to any panelist. I'll just read it now, and if you would like to jump in, please feel free to unmute. Civil society is often at the forefront of highlighting critical issues to policymakers and suggesting solutions, which are often successfully passed into policy, commitments, etc. The next step is to translate these commitments into practice and impact. Where and how should civil society engage further to make that next step happen? Yes, RD, I welcome you to answer this question.
I think as activists and as advocates, we know that our work doesn't stop with solving one part of the puzzle. If it's policy advocacy, yes, indeed, it's important to have either one, good policies that weren't existing before to exist through our work, or to repeal the policies that we do not like, that we want to be changed. If we are able to achieve that already, then that means we go into making sure that people understand what the policies are. We work with the government to make sure that the implementing rules and regulations are in favor to the spirit of the policy that we fought for. We need to make sure that we're also allocating sufficient budget for that. We need to make sure that the implementation lives to the true spirit of the policy. So what I'm trying to say is that advocacy happens in advocacy and the work of communities and civil society needs to happen at various levels, from crafting policies to monitoring, to program design, to implementation, to budget discussions and allocation. We have to be everywhere. It doesn't mean that one organization or movement will do everything, but it means that we have to, be watchful and also have the support to do the roles that civil society and advocates are good with, and that is seeking accountability, raising the issues to make programs effective for the communities that we serve. Thank you.
Thank you so much, Ardi. Also going to go to a question to Collins. Collins, if you're there, the question is from Roseanne Rushing. What areas of the toolkit are most important or useful for implementing and advocating for your program on women and girls living with disabilities? Do you find that the toolkit was applicable to your program in terms of content and accessibility? So Collins, if you would like to take that.
Yeah, thank you very much. I think that is a very good question. And according to me, I think the toolkit is very, very much useful to us. And I cannot say that some sections are good. I believe that each section is good for us because it's going to assist us do community organizing and how we can now involve other key partners in matters advocacy in our communities. And I think this toolkit is going to assist us. In fact, we are going to do a lot more in terms of advocacy, speaking for the rights of girls and women with disability in Bungoma County. Thank you.
Thank you so much, Collins. Can I also ask a similar question to Eliana? When you were considering the sections of this toolkit, thinking back to how it was developed, can you speak a little to why those sections were included and where that prioritization came from?
Yeah, great question. Thank you, Karthi. So I think we originally came up with the sections based on the need from what we saw working with the civil society organizations, doing our advocacy sessions before the high-level meeting on UHC. And so we came up with these three parts based on that. And then we actually developed a survey and we sent that out to civil society organizations just to test our theory a bit and to make sure that those three sections were in fact going to be useful. And in the survey, we dug a little bit deeper as to what subsections would be in each section. And then we actually asked civil society, is there anything else, any other tools or resources that would be useful in the advocacy work that you do? So all of this is really built and made for civil society and also by civil society. You'll see our CSEM advisory group played a very big role in reviewing the technical components. And then we also had other partners outside of CSEM that also work with civil society give us their inputs. That's not to say that it's perfect, and we continuously want to improve this toolkit. There is a section of the toolkit that you'll see that allows you to provide us with feedback and suggestions. So if there is anything missing or anything that we can add to keep improving the toolkit and responding to the needs of civil society, I highly encourage you all to use the toolkit and to send us that feedback so we can continue to make something that's useful and effective.
Thank you, Eliana. Yeah, great point about the feedback form and the fact that this toolkit is very much a live resource. One more question from the chat box to any panelist. It's about digital health. How can digital health support and harmonize UHC, including like leaving no one behind, and equity goals? Sorry, I'm having trouble seeing hands. So can I actually ask this to Justin? Justin, can you speak about this from a UHC 2030 perspective, both in terms of like, how do you see this toolkit fitting with this larger advocacy goals of UHC 2030? And then if you could also speak to digital health and the new resources we have.
Sure. So to your first question about how the toolkit fits into broader UHC 2030 objectives, maybe I'll just take a step back and explain how UHC 2030 is structured for those who are a little bit new to the partnership. So our steering committee is intentionally multi-stakeholder, and on the steering committee are member states, high, middle income, low income, as well as the philanthropic foundations, multilaterals, World Bank, WHO, OECD, Gavi, Global Fund, philanthropic foundations, did I say that? The private sector, and also civil society. And each of the constituencies organizes in their own way, but with a common goal. And so on some things, we will agree 100%. On some things, some of the constituencies can possibly say things that other constituencies might find more difficult. And so the civil society constituency has been enormously active in UHC 2030 and throughout the movement. And I guess we see the role of civil society. I am obviously, well, maybe not obviously, but I am civil society as well as my, I'm now co-chair, but definitely my heart is with civil society. Typically, civil society can push things a little bit further than perhaps some of the other constituencies can. We saw that. I mentioned the key asks for the UHC movement. What I didn't mention is that CSEM and civil society had its own key asks for the high-level meeting, which went a little bit further than the broad asks. And I think that's a terrifically important role, that the civil society can push a little bit further, and in doing so, keep governments and other stakeholders accountable in a constructive way. It doesn't always have to be angry. It can be very constructive, but we'd see the toolkit as completely aligned to that. So the entire movement, not just civil society, needs civil society to be successful. When we push for civil society inclusion, it's not just for ourselves, it's not just for civil society. We always say when we meet with Dr. Tedros that we need him and we need WHO, and they need us just as much. And so we see this work as critical, not just to civil society empowerment, but the whole movement. To the question on digital health, clearly that's critical, because digital health in many countries which haven't had as much access to traditional forms of health care and health services is progressing at an alarmingly positive rate. And so we need to utilize all of the avenues we have to access people who might not be able to access services otherwise. Obviously, there are issues of digital divide, and we have to be really careful that the use of digital technology doesn't create haves and have-nots. In other words, increasing inequity rather than decreasing inequity. But there are some really important partnerships. There's a lot like Transform Health working on digital health very actively at the moment. There is a Lancet Commission on Digital Health, which has done some terrific work. So it's certainly at the forefront of our thoughts, and we would, at UHC 2030, very much welcome continued discussion about how we can include digital health better in our work. So thank you for that important question.
Thank you so much, Justin, for jumping in so quickly with that. One more question, and then I think we can follow up in future events. A question from Ofra Balban. Can we have a mentoring program? And I want to direct this question to Eliana to talk more about our plans for this toolkit.
Yeah, thank you for the great question. So the CSEM has been working really hard to think about what we should do next beyond just putting this toolkit out into the world in hopes that civil society will use it. So I think the first step for us was, let's launch this and have civil society and communities use the toolkit. There is a tab in the toolkit where you can get technical support. And then also in the feedback form, if you need any support or would like anybody from the CSEM to take a look at anything you put together related to your advocacy plan, we're happy to do that. But I did just want to note and to let everybody know that we are right now thinking about what the next step will be in this toolkit and how we can support civil society and communities to not just develop strong advocacy planning, but also how we can support them in implementing the advocacy work that they're doing. There are a lot of events that are going to be coming up, especially around UHC Day, where you all are going to have the opportunity and the spotlight to be doing a lot of advocacy for global health and for universal health coverage. So stay tuned on CSEM News, and we'll be in touch soon with what the next step will be beyond this toolkit, but know that we're working on it, and we hope to work more closely with you all to actually turn this toolkit into action at the country level, regional level, and also global level. Thank you.
Thank you, Eliana. And just to close today, thank you all for being here today as we launch this toolkit and having this really engaging conversation about civil society engagement. We would like to thank Rebecca Webb, who just answered a question in the chat, and Equal International for their work on the toolkit, our wonderful reference group with civil society representatives across the sector for making this toolkit what it is, the CSEM advisory group for always providing technical support and moral support as well as all the co-organizers of this event. Our wonderful speakers were found by a group of great collaborators, including APCASO, Aidsfonds, GNP+, the Love Alliance, White Ribbon Alliance Kenya, UNAIDS, IFRC, the Georgia Red Cross Society, Management Sciences for Health, WACI Health, and Living Goods, and NCD Alliance. Really grateful for all the partners who've made this event possible, and the panelists for being such a great, having such a great enriching conversation today. We will be presenting the toolkit again next week at the C20 Summit on October 7th. Please feel free to share that invitation with your networks if you found this session useful. The toolkit is now available online at csеmonline.net. You may also contact the Secretariat at csem@msh.org to discuss anything more. As we've mentioned multiple times, this toolkit is very much a live resource, and we're hoping that it will continue to be updated as new information becomes available, as we hear more needs. So if you have any complementary resources that you would like to add to this toolkit, if there are sections that you think should be expanded on, please feel free to let us know. This is definitely a collaborative process and a work that will continue. Following these introductory sessions, starting next month, we will organize a series of in-depth workshops by region to increase familiarity with the toolkit's content, reach a range of CSOs in country, and facilitate networking among civil society and community advocates in this space. So thank you all so much. The link of the toolkit will be in the chat box. Hope you have a great rest of your day.
Thank you.
Thank you.
Thank you.